Alright, so hello everyone, I welcome you all. Hello everyone, good afternoon everyone. Alright, so I'm starting with the session 2 of PSM. I'm starting with session 2 of PSM. So now, my session is about keywords, mnemonics and some high yielding topics. My purpose at the end, you will be able to revise these topics in just 1 to 2 hours. It includes all recent PYTs. My suggestion, if you are writing with me, please use some small font, right? Small fonts. And what I'm going to include is epidemiology, screening, concept of health and disease, nutrition, NCD, demography, MCH, communicable disease, vaccines and health programs. All right, boarding started. Let's go. All right. I know this is boring. I know PSM is boring, but it is boring. It doesn't matter. What matter is it is high yielding. What matter is this is high yielding, right? This is high yielding. Now, first topic, morbidity indicators. What is incidence? What is prevalence? Incidence is number of new cases divided by population at risk. Prevalence is new plus old cases divided by total population. What is the multiplier in incidence? 1000. What is the multiplier in prevalence? It is 100. If numerator is part of denominator, and multiplier is 1000, it is a rate. If numerator is part of denominator and multiplier is 100, it is a proportion. Which study gives us incidence? It is cohort study. Which study gives us prevalence? It is cross-sectional study. Right? All set, all sorted. This topic, incidence, prevalence. Now guys, in your workbook and also on your screen, I have given you an image. There is a tub, the water coming and some water already in the tub. Right? Some water already in the tub. The water coming is the new cases in the community. The tub is our community. The new cases are coming and some already cases are there. Some old cases are also there, right? So, if the water keep on adding in the tub, prevalence is increasing. If the water is decreasing, prevalence is decreasing, right? This depends upon duration. Longer the duration, more is the prevalence. Right? Now, coming to good cure. If there is a disease, we have a very good cure. In 2 or 3 days, the patient is absolutely fine. Duration is less. If less duration, incidence will decrease. Now coming to highly virulent. There is a disease which is highly virulent. More deaths means less duration, right? If a disease is highly virulent, more people are dying, right? Highly virulent, duration is less. Duration of stay of that patient in the community is less because it is highly virulent. Within 2-3 months, the patient will be dead. Duration is less. So it is going to decrease the prevalence. If I have a treatment which is prolonging life but not curing, the disease, the duration will increase. So it will increase. And next is good immunization. Good immunization will decrease. Pre-exposure prophylaxis, any kind of prophylaxis, pre-exposure, post-exposure, immunization, your immunoglobulins, anything which is not letting the disease to happen. What will happen? There will be decrease in incidence. Right? So today there will be decrease in incidence. After some time, prevalence will also decrease. Slide number 1. Sorted? Any doubt in this slide? Right? So guys, this session, DVT session is all about keywords. I'm not going in depth, right? I will not go in depth, just keywords, high yielding so that we cover maximum important topics. Can I go ahead? Okay, guys, can I go ahead quickly? Can I go ahead? Coming to next slide. Mortality indicators. Number 1, crude death rate on your screen. What is crude death rate? Number of deaths in a year divided by mid-year population. Mid-year population taken on 1st July multiplied by 1000. So this is crude death rate. And if I talk about crude death rate, currently the data, India, the crude death rate of India is 6 per 1000. What about specific? So this is a crude death rate. Crude death rate, as a doctor, if I know the deaths are 6 in 1000 population, as a doctor, this is not of very much importance to me, right? I am interested in how much of them they are male or female or less than 5 years or elderly or rural or urban. As a public health specialist, I want to know these things. So then comes specific death rate. What is specific death rate? What is specific death rate? It is number of deaths divided by mid-year population in a specific group. Number of deaths in a specific group divided by mid-year population in specific group. This is going to tell me what? At risk population. Suppose a group of males, a group of female, more death in female. I can know that females are at more risk. So specific death rate will tell me at risk population. After that, I have proportional mortality rate. What is proportional mortality rate? Out of total deaths, how many are dying due to COVID? So if suppose 100 deaths in our area and 10 people are dying, and out of 100, 10 died because of COVID. So 10% of total deaths are because of COVID. This will tell me what? Burden of disease. This will tell me burden of disease, right? Now coming to case fatality rate. What is case fatality rate? Out of 100 cases of COVID, 10 died. Out of 100 cases of COVID, 10 died, right? So if I say, you must have heard about the Omicron variant, the Delta variant. The Delta variant, out of 100 Delta variant cases, 5 died. Omicron, out of 100, 2 died, right? According to you, which is more virulent, which has more killing power? The one which is killing 5 out of 100 or the one which is killing 2 out of 100? So yes, case fatality rate will tell you virulence. What is virulence? It is the killing power of the disease. It is killing power of the disease. Now, if I say out of 100, 5 died, this is case fatality rate. If I say out of 100, 95 survived, this is survival rate. This is survival rate. So what is survival rate? Out of total cases, number of patients are alive. What is case fatality? Out of total cases, how many died? Simple. But these two are used differently. These two are used differently. Case fatality is used for acute diseases, whereas survival rate is used for chronic diseases. Survival rate is used for chronic diseases, right? Now guys, there is a concept of standardization. I won't go in depth for your MCQ purpose. Just remember standardization. Why we do standardization? Standardization we do because okay. So what is standardization? Standardization, I'll tell you a concept in brief for your MCQ purpose, right? So what is standardization? Suppose crude death rate of America is 8, crude death rate of India is 6. Technically, more people are dying in US. Technically, as per this example. Can I compare these two? I cannot. Why? Because different population. India is having more young population. Japan, US, they have more elder population. I cannot compare these two. So whenever we have to compare death rate of two countries with different population, we use standardization. There are two types of standardization. Number 1, direct. Number 2, indirect. Direct is used when age specific death rate are given. Just remember this point. 2 points I want to know regarding this topic. Just 2 points. Number 1, whenever there is population difference, standardization is used. Number 2 point, If age specific death rate is given, direct standardization. If not given, indirect standardization. From this topic, only 2 related to your MCQ. Slide number 2 sorted, right? Guys, this whole discussion in your workbook also you will see, this whole discussion is about 10 to 12 pages and hardly 45 to 46 slides. That's it, right? So please, if you are writing, write in small fonts. Can I go ahead? Can I go ahead? Guys, can I go ahead? Now, study designs. What is a case report? What is a case report? What is a case series? You are sitting in your OPD. You vaccinated 2 people for COVID vaccine. They came with the unusual presentation. Retinitis. Retinitis is not a side effect of COVID vaccine. You want to publish this information. If you have one case, what is case report? Publishing rare clinical findings. If you have one case, you want to publish rare clinical finding of one case, it is case report. You want to publish rare clinical findings of a group of patients, same patient, suppose 100 patient after COVID vaccine, they developed retinitis. Case series. One patient after COVID vaccine developed retinitis. Case report. Fine. Now, this is case series, case report. Now coming to ecological study. Now coming to ecological study. Everyone, please focus. Ecological study is very important. What is ecological study? Ecological study, suppose I want to compare the sales of cigarette with incidence of myocardial infarction. What I did, I just took the number of cigarettes sold in every country and the incidence of myocardial infarction, and I plotted them on a scatter plot. Scatter plot पे plot कर दी ये information. This will give me, scatter plot will give me correlation. That is why ecological study is also known as correlational study. It is known as correlational study. This is the weakest study design. Now I found that number of cigarettes, if high in an area, will give more myocardial infarction. So there is no association. I am not able to tell you about any association. That can be a coincidence. That is why we cannot comment. This is a weakest study design. Now here, unit of study, I am not taking one patient here. I am taking a group of patients from America, a group of patients from India, a group of patients, right? So unit of study here is population. The problem here is ecological fallacy. What is ecological fallacy? It is basically ecological fallacy is characters ascribed to a group may not be possessed as an individual. Now, if someone say that people from Haryana, they are loud, it doesn't mean every person from Haryana is loud. No, that is not true. Ecological fallacy. That is ecological fallacy. Right? Characters ascribed to a group may not be possessed as an individual. This you need not to write. This is in your workbook. I have just zoomed in. Right? In your workbook, I have given in small fonts, but here I have zoomed in so that you can have a clear vision. Now coming to cross-sectional study. Now coming to, yes, Sakshi, stereotype. Good. Now coming to cross-sectional study. So guys, are you there? Are you listening? Yes. How is the class going? Are you listening? Can I have your responses in the chat box? Can I have your responses in the chat box? Okay. How is class going? Good? Okay. Go fast. Okay. I will go fast. Perfect, beta, perfect. Superb, beta, superb. Thank you. All your messages, they are giving me a feedback. Right. Okay. Now coming to cross-sectional study. Guys, cross-sectional study. Superb, beta, superb. Okay. Now, guys, please focus now. Okay, please focus. Drop your pen, pencil, notebook. Just listen and look on your screen. Very important. In just 1 minute, you will never forget this cross-sectional study. So we are doing a cross-sectional study. You and me, we are going to a school. We went to a school and I asked, please go and check their hemoglobin level. You checked their hemoglobin level. You told me, sir, out of 100 students, 20 are anemic. What is this? This is prevalence. So cross-sectional study gives us prevalence. I'm also participating with you. I took their history of risk factor, whether their diet is poor, or if the females are there, heavy menstrual blood loss, their risk factors. So prevalence, you told me, I am giving you what? I am giving you the risk factors. You are giving me prevalence, I am giving you risk factor. I also said, okay, just tell me more anemic rural person or urban, more anemic girls or boys, more anemic less than 5 years, more than, what is this? Distribution. So it also tells us distribution of disease. It gives us distribution of disease. So you have anemic. Do you have any natural history of disease? You cannot comment on any natural history of disease. You have just patient. You don't know when the disease developed, how the disease developed. You don't know anything, right? All right. So this is no information on natural history of disease. Now, bache, there is one thing, temporal association. In a very simple language, what is temporal association? Risk factor. If I can prove risk factor came early, then disease happened. If I can prove this is temporal association. So can I prove here that diet was poor, then anemia developed? It can be there that anemia developed, then diet became poor. No. So no comment on temporal association. No comment on temporal association. Fine. So again, now we went to school. You told me 20% anemic. You told me 20% anemic. If tomorrow I go, there might be only 5% of them are anemic. But I'm not doing any follow-up. No follow-up here. No follow-up here. Just single examination. We are never going to do a follow-up on those students. Right? This is cross-sectional study. Now coming to case control study. So you and me, we want to assess whether smoking is associated with lung cancer or not. Today, we included a group of smokers. We included group of lung cancer patient. D+ is lung cancer patient. Disease is there. Then we included some controls who are control. So case control study. One question came in NEET PG 2022. If you have red pen, just write it there. NEET 2022. Right? Now, so we have one group of lung cancer patient. They are D+. We included controls. Who are controls? Everything same. Just they are disease free. A group of diseased, a group of healthy. Yeah, that's it. D+ lung cancer, D- healthy. We asked them about the history. Some of them were exposed. Some of them told that they were smokers. Some of them told that they were not smokers. Similarly, I asked from healthy people. They told me some of them were exposed and some of them were non-exposed. This is case control. What is cohort? Cohort, today I am going to include smokers. Today I'll make two groups, smoker, non-smoker. And I'm going to follow them for like 10 years, 20 years. And after 10 years, I will see how many developed the disease and how many did not. Similarly, those who were not smokers, how many developed and how many did not. This is cohort study. The problem here is that in case control study, I am going from effect today, which happened, to the cause. And cohort study from cause to effect. The problem in case control study is recall bias. They cannot recall. The problem in case control study is recall bias. If I ask you what you had last week, you won't be able to tell me. How can we expect from them they will give you a true history that happened 10 to 12 years back? We cannot. This is recall bias. But the problem in cohort study is I'm going to follow them for 10 years. There can be lost to follow-up. What is attrition bias? People left the study. I am calling them, okay, so what we do is, we do a follow-up, 1 month, 3 month follow-up, right? We are calling them, okay, come for follow-up. They are not picking your call. Some of them died. Attrition bias is lost to follow-up. Attrition bias is lost to follow-up. Now, the problem in cohort study is, it is more time consuming. It is more money consuming also. For 10, 20 years, you have to pay your doctor. You have to pay the person who are involved in this. The problem here is, in case control study, less money, less time consuming. Temporal association. I just told you temporal association. What is temporal association? So exposure came first and then it led to disease. If I can prove this fact that exposure came first, then developed the disease. If I can prove this fact, this is temporal association. In cohort study, I have included the exposed. I am following them. I can prove temporal association. But this cannot be proved in case control. Now, natural history of disease. Now you have smokers, right? So they developed cough, then the X-ray changes, then CT changes. Everything you can tell me. Everything can be recorded. This is known as natural history of disease. But in case control study, I cannot prove this. This is the best study for rare disease. Okay. If I ask you one thing, right? If I ask you one thing, that if 10,000 people, they are consuming alcohol, one will develop liver cancer, suppose, right? Now, for this one case, are you going to spend lakhs of money in cohort study? No. That is why case control study is the best study for rare diseases. It is the best study for rare disease. I don't want to spend lakhs of money for just one case. Here, strength of association is odds ratio, and here strength of association is relative risk, attributable risk, and population attributable risk. In next slide, I'll tell you in detail what is relative risk, what is attributable risk, what is population attributable risk. Now, sorted, case control cohort done. Now coming to retrospective cohort study. Guys, in retrospective cohort study, okay, just listen the story and then I will relate. So last year, NEET PG 2023, the question came. I'm quoting the same example, right? So guys, I want to prove that aniline dye is causing some cancer. The drawback if I do cohort is time consuming, money consuming. If I do case control study, the drawback is recall error. So in retrospective cohort study, what I did, I went to a factory, aniline dye factory. I said, give me, so I am in present, right? I am in present right now. I went to the factory and I asked them, give me past records. 20 years back, give me a list of workers who were there 20 years back. They gave me two lists. One, worker directly involved with dye. Second, in your college, you have teaching staff and some clerical staff. In factory, one worker directly linked and second is clerical staff. 2 records. So the one who was directly linked is my exposed. The clerical staff there is not exposed. Now, today I have a list. I have their phone numbers. I have phone numbers. Today I am checking whether they developed the disease or not. Now understood? So my message here is, if anything, if you find records in question, data of exposure from records, if anything you find in question, most likely it is retrospective cohort. Try to find records. Sorted? So our study designs sorted, right? Now calculations. Odds ratio, case control study. Relative risk, attributable risk, population attributable risk is your cohort study. This odds ratio is known as AD by BC. It is also known as cross product ratio. Relative risk is incidence among exposed divided by incidence among non-exposed. If relative risk is more than 1, it means there is a positive association. It means there is a positive association. Smoking, lung cancer, the relative risk is 2. More than 1. Right? More than 1 means positive association. If relative risk is less than 1, suppose 0.5 less than 1, it means negative association. It means the risk factor is not causing the disease, it is protecting the individual from the disease, right? And if relative risk is 1, it means incidence exposed is equal to incidence non-exposed, right? It means there is no association. The same question came in NEET PG 2022. The other name for relative risk is risk ratio. The other name for relative risk is risk ratio. Attributable risk, the formula is incidence exposed minus incidence non-exposed divided by incidence exposed. The other name is risk difference. The other name is risk difference. The population attributable risk is incidence total minus incidence non-exposed divided by incidence total, right? Divided by incidence total, right? Now, some student is asking me regarding ambispective, retrospective and ambispective. So this study is retrospective, right? Now, if I follow them for 20 years, right? So suppose, what is there here? Look here. Look here. So past records, and today I am looking for the disease retrospective. And if the people who were exposed in past, according to the past records, if I follow them for next 10 years, right? So this is now ambispective. This is now ambispective. Fine. All right. This slide also sorted. Now coming to RCT. Now coming to RCT. Very important. RCT. Now randomized control trial, they are very important. Just few minutes. Let me explain this with example. I want to know. Okay. RCT. Okay, guys, please focus. Please, just a minute. RCT. Guys, do focus on RCT first, right? Please focus on RCT first. This is very important. In one slide, your RCT will be sorted. Now, look. So, I have a new drug for hypertension. I want to do a study whether the drug is good or not. What I did, I have included the total population. So I have included all the patient with hypertension. Right? This is my total population. But I cannot do, right? Suppose they are 10,000. Right? So I cannot include these 10,000 people in my study, right? So what I will do is, I will choose from this 10,000, I will choose 1,000 people. From the 10,000, I will choose the 1,000 people. The problem here, many are old, many are young. Many are old, many are young. What if I just include all the young people? And I show that my new drug is a better drug. This is not good, right? Because the young people are not representative of whole population. The whole population includes young and old both. So these 1,000 people, they should be selected randomly so that it represents the whole population. Now, next thing. Now, sorted. Now I have 1,000 people. Now I have 1,000 people. What I will do, I will divide them in two groups. group A and group B. 500 in group A and 500 in group B. 500 in group A and 500 in group B. In group A, I will give old drug. In group B, I will give new drug. Right? Okay. I'm repeating again. So I want to test a new drug for hypertension. I have 10,000 people who are suffering from hypertension. I cannot include all of them. I have to select 1,000 from those 10,000. I should select in such a way that these 1,000, they are representative of whole population. That is why I will do random sampling. That is why I will do random sampling. Guys, the topic, okay guys, listen. Whenever there is a topic which I feel I need to explain, my speed will be a bit slow. Whenever I feel this topic has nothing to do with any understanding, my speed will be fast, right? So let me go with my pace. Have faith, have patience, right? Have faith, have patience, because I have to cater thousands of students are attending the live session right now. Okay? Now, okay, have faith. Shreya, I'll manage the time. Don't worry. Just have faith on me. Have faith on me. Just have faith on me, right? Because there are some topics which I get frequently, queries from you. Now I have divided. So what is randomization? Randomization is dividing in two groups so that they are similar. Again, what is random sampling? Choosing from the population so that it represents the population. Random sampling. What is randomization? Now I have selected people, dividing them in two groups. It is randomization. Random sampling and randomization, they are not same. So if I am doing the study, and I am stopping it here, just here I am stopping it. This is known as parallel RCT. This is known as parallel RCT. Now few people said, sir, you have given them old drug and you have given them new drug. This is not ethically good. This is not ethically good. Why these 500 people, they are getting new drug? I said, okay, calm down. What I will do is, now after few days, after the results from this point are announced, I will switch over. Earlier, those who got new drug, now I will give them old drug. Earlier, those who got old drug, now I will give them new drug. If I am doing the study here, this is known as crossover RCT. This is known as crossover RCT. Fine. Now, just a minute. This is crossover RCT, right? Now guys, just listen here. Just listen. So this is the design of RCT. Now, what is single blinding? In single blinding, the subject is not aware whether he is getting new drug or old drug. He knows he is getting a drug, but which one he is not aware. This is single blinding. If along with the subject I am also unaware, this is double blinding. Subject plus interviewer. Now, if subject with interviewer, subject is not aware which drug he is getting. I am not aware which drug he is getting. Also, the data analyzer. So I'll be collecting the data and giving it to one statistician. He is also not aware which drug he is getting. This is triple blinding. Now coming to external validity. Guys, just listen. Just listen. One minute, just listen. If this is random sampling, if I'm doing random sampling here, So this is random sampling, right? Now if this population is part of this population, right? So suppose if only young I have included in sample population, that means random sampling was not done. If only young people are included, now can I apply the result of this study to the whole population? I cannot apply, because the study population and sample population, they are not same. This is known as external validity. What is external validity? This is also known as generalizability. That means result of the study now can be applied to whole population. If random sampling was not done, then external validity will be less. Now what is internal validity? Internal validity means if randomization was done faulty, right? If randomization was not done, all the young people here and old people here, can I compare the results between new and old drug? No, this is internal validity. What is internal validity? Results of study are valid for study group. Is the concept clear, guys? Is the concept clear? Now coming to confounding. What is confounding? Confounding, now coming to confounding. Alcohol is causing lung cancer. Alcohol is causing lung cancer. Can alcohol cause lung cancer? Absolutely no. There is a third factor, smoking. There is a third factor, smoking. Usually those who consume heavy alcohol, they also consume cigarettes. They also smoke. It is not the alcohol which is causing the cancer, but it is the smoking which is causing the cancer. It is the smoking which is causing the cancer. So what is confounding? It is the third variable which causes the disease. It is a third variable which causes disease, right? It is the third variable which causes disease. Now, this is known as mixing of effect. This is known as mixing of effect, right? We are confused now. Is it alcohol or is it smoking? But effect modifier. Effect modifier means these two. So here, okay, one more minute. Here alcohol is not causing cancer. It is the smoking which is causing cancer. But in effect modifier, air pollution and smoking, they both are causing cancer in a synergistic way. There alcohol was not causing cancer, only smoking was causing cancer. But here they both are synergistic. This is known as effect modifier. This is known as effect modifier, right? This is known as effect modifier. Now ways to control confounding: before study, randomization, matching, restriction, right? And after study, and so there is one error, it is after study. It is after study, stratification. After study is stratification, right? After study is stratification. Yes, Sakshi, smoker in Delhi, right? After study, stratification. Now if I talk about level of evidence, the first is meta-analysis, then we have RCT, then cohort, case control, cross-sectional, case reports, and the last is expert opinion, right? The opinion should not matter in your personal life as well as the expert opinion. It should not matter. So this was all about confounding. This was all about confounding. So one person is asking about crossover RCT. Guys, if I am doing the study till here, this is parallel RCT. But after doing parallel RCT, now earlier the person who got old drug, now the person will be getting new drug, right? So this is kind of phase 2 of RCT. You know, this is kind of another phase where after doing the research, now we are switching over the participant. Earlier who got new drug, now he will get old drug, right? This is known as now coming to Hill's criteria. What is Hill's criteria? Specificity. What is Hill's criteria? Specificity. Cause is specific for disease. Cause is specific for disease. Cause is specific for disease. So what is Hill's criteria? Hill's criteria means, Hill's criteria tell us about the association. Simple. If anything is following Hill's criteria, that means the risk factor is causing the disease. So number one criteria says specificity. The cause is specific for disease, right? Next is consistency. In India, you found smoking is causing lung cancer. Similar results you should found in America, in Japan. Everywhere you do the study, you will find the same result. Temporal association. Temporal association. Cause is present before effect. Cause is present before effect. Right? I have explained temporal association in case control and cohort. You must be knowing it. Strength of association. Quickly in chat box, guys, quickly in chat box. Strength of association for case control. Quickly in chat box. Strength of association for case control. Strength of association for case control. Quickly in chat box. Very good. Odds ratio. For case control, odds ratio. So strength of association. If the higher the strength of association, it means more association. It means more association. Dose response relationship. If someone is increasing the dose of cigarette, 20 cigarette per day, he should get cancer quickly. Reversibility. If someone is quitting, then the chances of disease should decrease. Reversing the cause changes the outcome. Next is plausibility. Can you explain? Is it possible? You know, plausibility means, can you explain? Can I believe your explanation? Coherence. Coherence means, does it fit with existing knowledge? Does it fit with existing knowledge? Right? Does it, okay, Gokul, what is restriction? But restriction means, like, if I know that smoking is a confounder in case of alcohol and lung cancer. Restriction means I will not allow the smokers in my study. Only alcoholic, right? If person is alcoholic, he can participate in my study. If he is alcoholic plus smoker, I have restricted them. He is not allowed in my study. This is restriction. Fine, Gokul? Now, bias in epidemiological study. Recall bias. Recall bias is, I'm not able to recall the exposure. Interviewer bias, researcher is paying more attention to cases. Bergson bias, when I am not selecting the cases, or you can say controls, from hospital, right? When I am selecting from hospital is, it is Bergson's bias. Now, Niemann bias. Niemann bias is prevalence incidence bias. Prevalence incidence bias says, suppose I want to do a study, and in that case the disease is very much deadly. The disease is very much deadly, right? So I want to do a study, for example, rabies. I want to do a study, a detailed study on the patient of rabies. I included some of the patient, but after 5 days the patient died, right? Because of the low prevalence, right? I'm not able to do. This is Niemann bias. You need not to write this example in the box. I have just included to explain what is Niemann bias, right? I have not explained. I have just written this to explain the Niemann bias, right? And loss to follow up. Attrition is loss to follow up. In cohort study, there are thousands, right? There are thousands of member we have. Some of them die. Some of them, they do not pick our call. This is attrition bias. Then Hawthorne bias. What is Hawthorne bias? People change their behavior when they know they are being observed. In a cohort study, I have a smoker. 10 years, I am following them. Now, the smoker, he quit smoking, right? I was expecting lung cancer in him, but he quit smoking. People change their behavior when they know they are being observed, right? So, people change their behavior when they know they are being observed. Now, next is lead time bias. What is lead time bias? Screening is confused. with prolonged survival. Lead time biases. Screening is confused with prolonged survival. Screening is confused with prolonged survival. Publication bias. Negative studies. Negative studies are not published. I want to publish a study. So I did a study on effect of remdesivir. On COVID-19 patient. But unluckily, my study did not found any effect. So I submitted for the publication, and the editor of journal is not accepting the study because there is not a positive result in my study. This is publication bias. Selection bias. Cases and control are not representative. Cases and controls are not representative of whole population. Guys, Niemann bias means because of the different prevalence. I want to do a study on rabies. So I included some rabies patient in my study, and after 5 days he died. Because of, so Niemann bias is the hindrance. It is the bias which happens because of the different prevalence, the different duration of the study, the different duration of disease, right? Right? Okay. Now coming to concept of screen time and lead time. Okay. All right. I'll make sure, Revati, I will make sure I'll stand where you are writing, right? Okay, lead time bias. Lead time bias का मतलब क्या है? Lead time bias means, suppose I did a screening. Okay, lead time bias. Guys, listen. Lead time bias. Okay, look here. Suppose this is patient A, and this patient A developed. Okay, guys, I'm giving you lead time example. Please, I'm giving you lead time example. The disease started here. So the patient started breast cancer at point A. In 2008, the patient developed breast cancer. In 2015, she came to OPD with the lump, and in 2020, she died. There is another patient. She also started breast cancer in 2008, right? It started in 2008, and we did a screening in 2012, and we found the lady is having breast cancer. She died in 2020. She also died in 2020. Now, after coming the symptoms, she lived for 5 years. But because I did a screening, after my screening, she lived up to 8 years. Right? So if I do screening, after screening, she lived up to 8 years. This is lead time bias. Do you really think that lady B, because of screening, she survived more? No, that is not the case. We just came to know earlier, but the actual life is same. This is known as lead time bias. Lead time bias. Screening is confused with prolonged survival. Screening is confused with prolonged survival. Done? Now coming to the screen time. So guys, what is screen time? At point A, the disease started. At point, okay. So guys, I have one humble request, right? So right now, you must be having a doubt in a topic, right? So let us just pause whatever doubt you have. I understand, I respect that you have doubts, right? That means you are listening, but can we just pause and keep those doubts aside, and can you just be with me in this slide, right? Can you just be with me in this slide? If if I explain previous now, I won't be, if you will focus on the lost topics, definitely you are going to lose this topic also. Definitely. Let us not focus. If any point or line you could not keep, just keep it aside and focus here. Because if you focus on that, you are going to lose another topic, this topic. Right? Just be with me. Right? Now, so disease started at point A. Then there is a point B where for the first time you can detect the disease. You do anything, you apply any test in the world, you are not going to detect the disease before point B. Point B is the point where we can detect the disease for the first time. Then we have point C. The point C is the final critical point. If you screen after point C, you are not going to make any difference in the outcome of the disease. Right? After point C, if you do screening, you will not reverse the disease. Right? Then there is a point, usual time of diagnosis. What is usual time of diagnosis? Now, in this time, the patient will be having lump, the patient will be having symptom, and the patient will be coming to your OPD. And then is point E, which is known as outcome. Which is known as outcome. There are only 3 outcomes of every disease: recovery, disability, death. These 3 outcomes, every disease, only 3 outcomes. Right? Only 3 outcomes. Right? Now, you have to tell me what is the best time to screen a patient. Is it between B to C or B to D? Right? I know B to B is best. Yes, we all know B to B is best. But here I want to know here B to C or B to D. Yes? Guys, quickly. Quickly. In your chat box, quickly. B2C is the right time to screen. That is why this is known as screen time. If you do after C, if you screen after C, you are not going to make any difference. So that is why the best time to screen is B2C. This is known as screen time. This is known as screen time. And then we have B2D. So when is the disease coming? The patient coming to your OPD at D. Usual time of diagnosis. If somehow you do any test and you detect before D, are not you leading the disease? Because disease is coming at point D. So that is why this is known as lead time bias. This is known as lead time. I'm sorry, only lead time, not lead time bias. Tongue slip. Lead time, right? Screen time, lead time. Now this concept sorted. Now guys, I'm coming to a very important. This is not the right time to explain you about sensitivity and specificity, but definitely this is the right time to make you learn so that you do not make any mistake in your exam. Guys, what is sensitivity? What is sensitivity? Right? Look here. Now, guys, listen here. What is sensitivity? What is sensitivity? Sensitivity is, suppose, guys listen, suppose my watch tells me the BP. Suppose my watch tells me the BP. This is my screening test, right? So what is sensitivity? Sensitivity is out of total diseased, how many are true positive? So the formula of sensitivity, true positive divided by TP plus FN, right? TP plus FN, right? So the formula for sensitivity is out of D plus, right? So these two are diseased. These two are diseased. Okay, I'm repeating again. Listen, focus, right? Focus, guys, focus. So suppose these two are, okay, I'm repeating again. Guys, just 1 minute, I'll repeat this. Suppose I have a screening test. I have a screening test for HIV. And okay, let us take example of COVID. I have rapid test, and this is my screen test. And I have RT-PCR. This is my diagnostic test. Those who are positive on diagnostic test, they are D+. Those who are negative on diagnostic test, they are D-. They are D-. Right? Now, what is sensitivity? Sensitivity is true positive divided by D+. Right? D+. True positive divided by false negative. And what is specificity? True negative divided by D-. True negative divided by D-. Now, okay, again. So what is sensitivity? Out of total diseased, how many positive on screening test? Out of total disease, how many positive on screening test? Sensitivity. What is specificity? Out of total disease free, how many are negative on screening test? This is specificity. What is positive predictive value? It is out of total positive on screening test. Out of total positive on screening test, how many are true positive? Out of total positive on screening test, how many are true positive? So here denominator is true positive plus false positive. And here denominator, what is negative predictive value? Out of total negative on screening test, how many are true negative? Right? How many are true negative? Done? Okay. Now coming to next. Now coming to cutoff value. So guys, this is, okay, now coming to cutoff value. Listen here. So this is a cutoff. This is a cutoff. This is a cutoff. Right? Those who are above the cutoff, they are diseased. Those who are below cutoff, they are disease free. Right? They are disease free. Right? They are disease free. Now, if I decrease cutoff, if I decrease cutoff, what will happen? Okay. Okay, guys, please. Okay, I understood. Fine. Now, listen here. Now, this is the cutoff. Those who are above the cutoff, they are diseased. Those who are below, they are disease free. There are some people who are actually diseased, but they are below cutoff. Who are they? They are false negative. There are some people who are healthy, but their value is above cutoff. They are known as false positive. Now, if I decrease the cutoff, what will happen? The false positive will increase. The false negative will decrease. The false positive will increase. The false negative will decrease. Right? And if I increase the cutoff, what will happen on increasing cutoff? False positive will decrease and false negative will increase. False positive will decrease and false negative will increase. Now, coming to ROC curve. What is ROC curve? It is a curve drawn between sensitivity and 1 minus specificity. Sensitivity and 1 minus specificity. Right? Now, the other name for sensitivity is true positive rate. Other name for 1 minus specificity is false positive rate. False positive rate. Now, what is ROC curve? What is ROC curve? So, this curve is used to determine cutoff. This is to determine cutoff. This is used to determine cutoff. Right? Now what happened? This is 1 cutoff. This is 2 cutoff, 3 and 4. Right? Now cutoff 1 is the best. Cutoff 1 is best. Guys, why this is best? Because at any point you see, it gives you maximum true positive rate. Suppose this point. Here you have maximum true positive rate and minimum false positive rate. And minimum false positive rate. And minimum false positive rate. So just 2 points in ROC curve. It is drawn between sensitivity and 1 minus specificity. Other name for sensitivity, true positive rate. Other name for 1 minus specificity, false positive rate. It is used to determine cutoff. It is used to determine cutoff. And cutoff 1 is the excellent cutoff because it has maximum true positive rate and minimum false positive rate. Right? Now coming to index, Human Development Index. Human Development Index, it contains 3 things: knowledge, income and life expectancy at birth. I have a mnemonic. The mnemonic is, hey, don't kill at birth. Hey, don't kill at birth. K stands for knowledge. I stands for income. Life expectancy at birth. Life expectancy at birth. Right? Now, knowledge. This includes mean year of schooling. This includes mean year of schooling and expected year of schooling. Expected year of schooling. Right? Knowledge, income, life expectancy at birth. And now we have physical quality of life index. The mnemonics is ill at the age of 1 year. Ill at the age of 1 year, infant mortality rate. Then we have literacy, and then we have life expectancy at 1 year. Life expectancy at 1 year. Right? Now, Global Hunger Index. It includes M. The mnemonic is MMM. It is child mortality, child malnutrition, and malnutrition in overall population. Malnutrition in overall population. Malnutrition in overall population. Now, this was your NEET 2021 question. This was your NEET 2021 question, and other than these 3 options, it was infant mortality rate. Infant mortality rate is not included in Global Hunger Index. It is not included in Global Hunger Index. Right? Now coming to Multidimensional Poverty Index. The Multidimensional Poverty Index is health. Now, in health, education and standard of living, 3 things are included in Multidimensional Poverty Index: health, education and standard of living. In health we have 2 things: nutrition, child mortality. We have education, year of schooling and school attendance. And last we have, in standard of living, we have housing, sanitation, electricity, drinking water, cooking fuel and assets. So this was about these 4 indicators. Trust me, this is a 5-star topic. This is a 5-star topic, right? This is a 5-star topic. Very, very, very important. Very important, right? These 4 are very important. Now coming to the concept of health and disease. First is quarantine. Quarantine is done for contacts, whereas isolation is done for cases. If someone is diagnosed case, isolation. If someone came in contact, then quarantine. We are keeping one person away from all of the community in a room because he is a contact. Why? Till what time? Maximum incubation period. What about isolation? What about isolation and What about isolation? This is done for cases, and this is done till period of communicability. This is done till period of communicability. Now guys, active surveillance, right? Active surveillance. Okay, active surveillance. Now coming to active surveillance, this is about quarantine. This is about quarantine. Now coming to active surveillance, what is active surveillance, right? What is active surveillance? Active surveillance is, suppose, okay, let us take example of COVID. So when the COVID came, the health department got a notice that you have to go house to house to see how many are having fever. This is active surveillance. When we go house to house, this is active surveillance. Now we were in hospital and we made flu clinics, fever clinics. People were coming to our clinic and we were doing their COVID testing. This is passive surveillance. When cases are reported to health facility, passive surveillance. What is sentinel surveillance? Sentinel surveillance is it is done for missed cases. So I was going house to house. My duty time is 9 to 4. The person is also doing some job. Duty time 9 to 4. He was not at home when I went to the home. He is not coming to the hospital because of the duty timings or because of any fever. I was missing that case. What I did. So I made some sentinel sites. Some sites where there is probability of those cases. For example, the toll tax, the toll booths. I started doing testing there. This is for missed cases. This is done at sentinel sites. Now coming to level of prevention. Beta. Now, bacham, listen to me very carefully. 1 point, 2 point if you missed, right? If 1 point, 2 point you missed, you'll be getting PDF. You'll be having the video. Why you are wasting the present slide because of 1 point missed, right? Because of 1 point missed. Now you are talking about your lunch. Many people, they are saying about lunch. I also, my staff also, everyone, right? You will have lunch time. Trust me, you will have lunch time. Nobody is taking your lunch, right? Nobody is taking your lunch, right? We teachers, our staff, we have prepared for these slides. You know, these slides, this is not just 1 minute or 2 minute show. It took me days to compile all of this. Just the keywords so that in just 1 or 2 hours, you revise the PSM, right? Please focus now. Humble request, right? A humble request, right? A humble request. Do you want me to fold hands for this humble request, this simple humble request? This is for you, yaar. Come on, right? Okay. Now coming to primordial prevention. This is one topic which is very important. Every year they ask you one question. Primordial prevention. This is done before occurrence of risk factor. This is done before occurrence of risk factor, right? What is primordial prevention? Risk factor is not there. I am telling you one very important thing, which this is one topic, level of prevention. No one is there without any doubt, without any controversy, without any confusion, right? No one is there. No student is there. Trust me, this is my experience, right? Somewhere this topic creates controversy. Now, primordial prevention. There is no risk factor till now. We want to do before the risk factor occurs, right? What you can do? Only you can give health education, right? Only you can give health education. And the special point is, this is the best level for NCDs. This is the best level for NCD. Your previous year question, best level for NCD. Now there is a risk factor. Now risk factor occurred. Risk factor is there. right? The risk factor is there. Now risk factor is there, but disease started? No, disease has not occurred yet. What you can do at this point? Risk factor is there. The person is obese. The person is obese, right? The risk factor is there. What you can do? You can just advise health promotion. Active, you can advise health promotion. A good lifestyle, a good diet, some physical exercise. And second is specific protection. For example, we can advise vaccines because the risk factor is there in our environment. Now the example of this level of prevention is all vaccination and hand washing, be it in ICU, be it at your home, be it before having lunch, dinner, anywhere. Hand washing is primary prevention. Pre-exposure prophylaxis, post-exposure prophylaxis, all of them are primary prevention. Using mask is a primary prevention, right? Now coming to secondary prevention. Secondary prevention is now the disease started and the disease is in early stage. What you can do, what you are doing, right? So the level of prevention, we want to minimize the human suffering. We want to minimize the human suffering, right? So disease is in early stage. What you can do here, you can early detect the disease, early detection and treatment, early detection and treatment, right? Early detection and treatment. Now, next is, what is the example? Screening of disease. Screening of disease is secondary prevention. You are going on a health camp and you are screening mammograph, right? Mammogram. That is screening of disease. Pap smear, you are detecting the disease. Then comes tertiary prevention. Now the disease is beyond early stage. Now the person started developing disability. Number one, disability limitation. You try to limit the disability. And second is rehabilitation. Whatever disability happened. Number one, disability limitation. The person is disabled. You do something that his disability does not progress. Second, whatever disability happened, do something so that he can learn, he can live his life, he can earn some livelihood. That is rehabilitation. Sorted? This topic also sorted? Now, yes, self-breast examination is also secondary prevention. Self-breast examination is also secondary prevention. In the chat box, lead apron. We are advising radiographers to wear lead apron. What level of prevention? In the chat box you have to write. I am moving to the next topic. In the chat box you have to write. Yes, in the chat box you have to write. Yes, lead apron is example of primary prevention because the risk factor, the X-rays are there, the risk factor is there, but disease has not occurred. Primary, very good beta. Now coming to obesity, we have some obesity indicators. BMI, the formula is weight divided by height square. Then Broca's index, height in centimeter. Height in centimeter minus 100 should be the ideal weight. If someone is having 175 centimeter height minus 100, the ideal weight for that person is 75 kgs. Bro, right? So guys are usually obsessed with their height. Bro ka height, mnemonic. Ponderal index, this ponderal index is different from your pediatrics ponderal index. Here, this is for obesity. Height divided by cube root of weight. Then comes corpulence index. Yeah, it is meter. Okay, I'm sorry. It is meter. I'm sorry. Just a tongue slip. It is meter. Guys, it is meter. Meter. Fine. Meter. Thank you. Thank you for reminding. Thank you. Right? It is meter. Then corpulence index, height. The corpulence index is the only index where height is not considered. Actual weight divided by desired weight should be less than 1.2. Should be less than 1.2. And then we have Lorentz index, height minus 100 minus bracket height minus 150 divided by 4 if it is a male. And 2 it is a female. And 2 if it is a female. Now skin fold index, skin fold thickness, this is her pendant caliper. This is used to measure the skin fold thickness. 4 sites are used: triceps, biceps, suprailiac, subscapular. Right? 4 sites are usually used for measuring the skin fold thickness. So I think this slide is yes, ABCD, that can be specific protection. Right? Now coming to WHO steps approach. Guys, one slide with maximum PYQs, one slide with majority of PYQs, and every topic is important from this slide. Every topic, right? So this slide will give you one question in exam. What is steps approach? In steps approach, this steps approach is for NCD screening. So we go to a village. In that village, first point is we use a questionnaire. Right? In that questionnaire, we ask about the demography, the age, gender, right? And the risk factor, smoking, alcohol habit, all of the daily routine habit, physical activity, all of these. This is the questionnaire. If we find someone is at risk of NCD on questionnaire, we go for physical measurement. We measure the height, the weight, and we measure BMI, all of the physical measurement. And if on physical measurement we find someone is at risk of NCD, then we go for biochemical. Blood sugar examination, cholesterol, all the lipid profile. This is WHO steps approach. This question, WHO steps approach, was there in your NEET PG 2022. Right? The fourth option was therapeutic. No treatment is there in WHO steps approach. This is only for screening. Then next is tracking of blood pressure. This question was there in your NEET PG 2023. What is tracking of blood pressure? It says if we track blood pressure of an individual, then from childhood to adulthood, right? So if childhood a person is having low blood pressure, when he will be adult, he will be having low blood pressure. If in childhood someone is having high blood pressure, when he will be adult, he will be having high blood pressure, right? This is tracking of blood pressure. Now NEET PG 2022, NEET PG 2023. Now rule of half. Rule of half is for hypertension. Out of the total population, 50% is having hypertension. Out of those who have hypertension, 50% are diagnosed. Out of those who are diagnosed, only 50% are taking the treatment. Out of those who are taking the treatment, only 50% they have controlled blood pressure. Now, coming to the next topic, most common cancer. Most common cancer, Globocan 2020 data for India, most common cancer, and we have recently ICMR. Now, the most common cancer according to Globocan in male is lip, oral cavity. In female, it is breast. In female, it is breast. According to ICMR, in males, it is lung cancer, right? And overall, if we say breast cancer in both gender is the most common cancer. If nothing is mentioned, right? If nothing is mentioned, then you follow Globocan. Then if nothing is mentioned, you follow Globocan. Now coming to one important, I have a gut feeling, 90, 70, 90. This is very important for your exam. I have a gut feeling they may ask you this exam, right? 90, 70, 90 is for cervical cancer. 90% girls should be vaccinated for HPV vaccine. 70% eligible should be screened. 70% women should be screened. And on screening, if you find any precancerous lesion or cervical cancer, 90% of them should be treated. 90, 70, 90. The mnemonic is VST. Vaccine, screening, treatment. 90, 70, 90. VST. Vaccine, screening, treatment. Now coming to a very important chapter. Yes, 90, 90, 90 is for HIV. Very good, bache Akul. Very good, beta. 90, 90, 90 is for HIV. We'll be discussing that. So, I'm coming to a chapter highly important. Nutrition is very important, right? Nutrition is very important. Majority of the questions, they come from this chapter. Why? Right? So why nutrition is important? Because your vitamins last year, right? Majority of the question from nutrition. And if I talk about nutrition, majority were from vitamins. Why? Because think like this, na? Biochem person, suppose I am a biochem faculty, I have to make a paper. So common topic, PSM people, common topic, pediatrics, vitamin deficiencies, common, derma, common. Likelihood of these topic is very high. That is why the reason is very high, right? Barabar? Chalo. All right. Now coming to RDA. Right? Now coming to RDA. Guys, I have a mnemonic to learn this, right? I have a mnemonic. Yes. Aritra Mukherjee, bache, ophthal also, vitamin A, ophthal also, right? Okay, so that Vasuli Bhai, can be added to the meme. Okay, guys, okay, one minute. If for next 1 minute you are with me, I guarantee you, I'll make you learn this. I'll make you learn this at any cost. Just 1 minute, be with me. Right? Okay, guys, female first. Do you agree with me? Female first, right? Female first. And if it is a secondary female, if it is a sedentary female, we should think first. 1600. You add 500. You add 500 for moderate. You add 600. You add 600. Right? You add 600 for heavy. And moderate female, a sedentary male requires similar energy as a moderate female. That is 2100. Again, if I add 600, 2700, and now I will add 700. Right? Just one thing. Rule number 1, female first. Which female? Sedentary female. How much? 1600. Add 500, 2100. Add 600, 2700. Moderate female is equal to sedentary male. How much? 2100. Add 600, 2700. Add 700, 3400. Sorted? Yes. Can I get sorted? Right? Sorted. Can I get some thumbs up in the chat box? Some thumbs up in the chat box. Yes. Some thumbs up, some smileys, some heart in the chat box, or fire in the chat box. Right? Fire in the belly. Fire in the belly will lead to fire in chat box. Right? Superb, beta. Superb. Chalo. Now coming to the protein requirement. Okay, I am deleting it. So I am erasing it. Chalo. Now next is protein requirement. It is 0.83 gram per kg. 0.83 gram per kg. Right? The weight of a male is 65 kg. If you multiply it with all right. Okay, so we are back. So there was a moe moment, but now we are back, right? Chalo, guys, thumb jao. Okay, shant. So guys, I was telling you one very important point. 65 kg man, if you multiply with this 0.83 gram, the requirement will be 54 gram of protein. If you multiply a 55 kg with 0.83, you will get 46. In pregnancy, plus 350 kilocalorie. In lactation in less than 6 months, plus 600. More than 6 months, 550. Right? 550. Okay. And in pregnancy, third trimester, 9.5 gram is required extra. And in second trimester, 9.5. In third trimester, 22 grams. In lactating less than 6 months, 17 gram. In lactating more than 6 months, it is 13 gram. Right? Now, guys, this dietary fiber, recently dietary fiber is in talks. So I feel this is important for your exam. So just 2-3 numbers you have to learn. 25. Again, sedentary female first. Here we added 500. Right? And now here you have to add 7. Here you have to add 7. Right? Here you have to add 7. Then you have to add 9. Similarly, it will be same for a male. It will be same for a male. And then you have to add 9. And here you have to add 11. You have to learn 4 numbers with me for dietary fiber. 25, 7, 9, 11. Repeat with me. 25, 7, 9, 11. 25, 7, 9, 11. And it will be sorted. For energy, 1600, 500, 600, 700. That's it. It will be sorted. Right? This is the thumb rule to learn this. Now, if I talk about reference Indian male, the age is 19 to 39 year. For female, same. The age is 19 to 39 year. The weight is 65 kg. Here it is 55 kg. The height is 1.77 meter, 1.62 meter. BMI 20.75 and here BMI 20.95. Right? 20.95. All pleasure is mine. Thank you, beta. Thank you so much. Thank you. Right? Yes, boarding started, boarding going on. Okay, now coming to RDA. This is NEET PG 23 question. RDA, just three points I want to tell you in RDA. It covers, point number 1, it covers 97.5% population. It is for mean plus 2 standard deviation. It is cover mean plus 2 standard deviation. Vatsal bachche, yes, 8 pages in 145. Bachche, that was epidemiology. I told you I'll be slow. Now just factual based, the speed will be fast. Why to worry beta? Why? Okay. And accept energy. Accept energy. Right? Accept energy. And EAR, it covers 50%. It covers 50%. Right? Just 3 points for RDA, 1 point for EAR. That's it. Right? Now, this is the RDA table for all the micronutrients. Just I want your attention that if I talk about zinc, then if I talk, okay, this RDA table, you need not to worry. This is just for, just a minute, I want to take the highlighter from here. Right? It is lactation, elderly, male and female who require more calcium. Apart from calcium, elderly, they require, apart from calcium, elderly, they require more vitamin D as compared to young. If I compare the female, if I compare a non-pregnant, pregnant and lactating female, then zinc is required majority by a pregnant woman. Iodine is required maximum by a lactating woman. Iron is required maximum by a pregnant female. Folic acid, pregnant, right? Folic acid, pregnant. Then vitamin A. It is required maximum in lactation. If I talk about these three, this is your MCQ, right? This was your previous year question. And vitamin C is required mainly by lactating. That's it. This is just RDA. This is just RDA. You need not to learn the values, but once iodine was asked in your exam. So guys, have a rough idea. Have a rough idea, right? Now coming to taste of milk. Guys, what is pasteurization? Pasteurization is boiling milk to kill the pathogen. So when the dairy farmers, they give milk to the company, right? For example, Mother Dairy or Vita. Mother Dairy or Vita is accepting milk from farmers, dairy farmers. They are going to do one test. Which test? The test is before pasteurization, the test is methylene blue test. And after pasteurization, 3 tests: phosphatase, standard plate count and coliform. If I talk about different milks, buffalo milk, goat milk, cow milk and human milk, then energy, fat and protein is maximum in buffalo milk, but it is the lactose which is maximum in human milk. If I talk about breast milk, energy per 100 ml 65 kilocalorie, protein 1.1 gram, protein 1.1 gram. Now these are some images. This is vegan. This is vegan. This is for fortified. This is for fortified. This is for these are just images, just logos I want to show you. They can ask you in exam. Vegan and fortified is, and this was introduced recently, so this is important. Just have a rough idea. Now coming to food adulterants and toxin. Guys, one बेटा मैं अपना लंच नहीं खा पाऊंगा शायद, आपका लंच तो कैसे खा लूंगा, बिकॉज आई हैव टू रश आफ्टर द क्लास, राइट? So how would I be able to eat your lunch, beta? You will have lunch time. Okay. Letharism. Letharism, it happens because of consuming khesri dal. Guys, for your NEET exam, every year one question from this slide is mandatory. In NEET period 2023, this was asked and this was asked. From one table, two questions. From one table, two questions. Letharism happens when khesri dal is consumed. Khesri dal contains BOA. Khesri dal contains BOA. The toxin is BOA. Now, how we can prevent? We can ban the crop. We can ban the crop, right? We can ban the crop, right? You can ban the crop, right? Vitamin C prophylaxis can be given. This was the recent MCQ. Which vitamin? Option were A, B, C, D. Answer was vitamin C. You can remove the toxin by steeping method. And last is genetic modifications. Do some genetic modification that the new crop of khesri dal will not produce the toxin. You remove that toxin producing genes. Do some kind of genetic modification. 4 steps. Okay. 5 points from this letharism. Number 1, toxin, BOA. Food, it is khesri dal. How you can prevent it? Ban the crop, genetic modifications, removal of toxin, and vitamin C prophylaxis. Now coming to epidemic dropsy, this mustard oil is mixed with Argemone mexicana, right? This mustard oil, this is for the purpose of cheating, right? This is for the purpose of cheating. But the Argemone mexicana, it contains a toxin, sanguinarine, and it causes epidemic dropsy. It causes epidemic dropsy. If I talk about the clinical features, paralysis. If I talk about clinical feature, paralysis. Epidemic dropsy, the clinical feature. Okay, you learn with the mnemonic is, which I usually teach in my class, the mnemonic is drop of mustard oil. Dropsy, drop, mustard oil is contaminated. So here I am talking about a drop. So whenever there are drops of liquid, that is the symptom. Example, let us take example. If the fluid is in joints, what do you say? If the fluid, edema, pedal edema. If the fluid is in eye, glaucoma. If the fluid is in heart, CHF. Right? If the fluid is in heart, CHF. Right? Now, next is, what are the tests done? Nitric acid test and paper chromatography. Nitric acid test and paper chromatography. Nitric acid test and paper chromatography. Endemic ascites, the toxin is pyrrolizidin. The millets are adulterated with crotalaria seeds, and we can do the de-weeding. Ergotism is a fungus. It is, okay guys, if I talk about fungus, there are 2 fungus. In this list you have to read. One is ergotism, another is aflatoxin. Ergotism is a field fungus. It is a field fungus. It is a field fungus. Kheton mein fungus lag gayi. That is it. It is a field fungus. What you can do? If you have found ergot infested grains, you soak in 20% water, and that will separate the infested grains with the good grains. Next is aflatoxicosis. It is mainly groundnut like maize, parboiled rice, right? Now, aflatoxicosis is a storage fungus. When you store the food and the fungus is there It is aflatoxicosis, right? In the field, in the crops, if there is fungus, that is ergotism. Now, coming to vitamins, right? Coming to vitamins, vitamin A. Okay, last few minutes, guys, last few minutes, and then we are done. These next few slides are very small slides, right? Next few slides are very small slides, hardly last 10 minutes, right? Last 10 minutes and we are done, right? So can we have patience for last 10 minutes? Can we have patience for last 10 minutes? Okay, vitamin A. If I talk about vitamin A, right? So vitamin A was your MCQ, vitamin B1 was MCQ, B3, every point is MCQ here. Vitamin A, the maximum, the richest source, one time this was asked, the richest source of vitamin A, halibut liver, more than cod liver. The symptoms are night blindness, Bitot spot, conjunctival cirrhosis. You will be reading this in detail in your ophthalmology. Under National Immunization Schedule, 1 ml of vitamin A contains 1 lakh international unit. So if first time we give vitamin A at 9 months, so 1 ml is given. Anyhow, you need to give it to less than 6 months. I'm not saying less than 6 months we give in National Immunization Schedule. It is given at 9 months. But if you need to give less than 6 months, it is 0.5 ml, that is 50,000 international unit. 6 months to 1 year, 1 ml. More than 1 year, 2 ml. Then if I talk about vitamin B1, this was the MCQ NEET PG 23. History of alcoholic, keyword, history of alcoholic, vernix encephalopathy. History of alcoholic vitamin B1 deficiency happens. This is known as vernix encephalopathy, ataxia, confusion, ophthalmoplegia, right? These three, this is the triad. And this also causes beriberi. This also causes beriberi. Vitamin 3, B3 is very important. NEET PG 21, 22, 23, even in inicet, one time this was asked. So vitamin B3 deficiency causes pellagra. It causes pellagra, right? And the symptoms are 4 Ds: diarrhea, dementia, dermatitis, and death. Diarrhea, dementia, dermatitis, and death. Now, the dermatitis we get here is a bilateral dermatitis, especially on sun exposed area. This is known as Casal's necklace. This is known as Casal's necklace. And this image was given this year, NEET PG 23. Vitamin D was also asked. This image was given. This is rickets because of vitamin D deficiency. And because of vitamin C deficiency, we get scurvy. Because of vitamin C deficiency, we get scurvy. Sorted? Done? Now this is all the high important points. Now coming to minerals. Iron. See, the iron, if I talk about iron, the most sensitive indicator for iron deficiency is serum ferritin. This was your PYQ, right? So keyword, most sensitive indicator, serum ferritin. If I talk about iodine, most sensitive indicator is prevalence of neonatal hypothyroidism. For surveillance, we use urinary iodine secretion, right? Urinary iodine is for surveillance, most sensitive indicator, prevalence of neonatal hypothyroidism. Now, if I talk about fluorine, then if fluorine is excess, it causes fluorosis. If deficiency, it causes caries. It is best seen, this fluorosis, initially, it is best seen as dental mottling, best seen on upper incisor. So once this image was given and they asked this is happening because of which mineral, the answer was fluorine. Now coming to next point about fluorine. Nalgonda technique. Nalgonda technique is a defluoridation technique used for fluorine. All high yielding points in a crisp manner and with the keywords, right? Now coming to quickly, like last point from this slide, zinc. Guys, zinc causes, this image was given. Guys, this year NEET PG 23, this image was given. right? This image was given. And they ask why this is happening. So zinc deficiency causes the mnemonic is DAD, diarrhea, alopecia, dermatitis. The beauty about this dermatitis is this is periorificial, around the mouth you can see, or you can get an image around the anal or around the genital area. Periorificial, the classical is periorificial. Okay? Now, TB algorithm. Guys, okay. TB algorithm. I cannot take any chance with this topic. For next 2 minutes, I want your extreme focus here. You are tired, you are hungry, I don't care. For next 2 minutes, it is my humble request. Please be with me. And after 2 minutes, it is my guarantee you will never forget this. Right? So this is a chaos. Can you look the chaos? But 2 minutes, focus with me. My guarantee you will never forget this in your life. Right? 2 minutes, extreme focus mode on. Right? Extreme focus mode. Right? So guys, you have a patient, presumptive TB. What is a presumptive case? Presumptive case is the case with sign and symptom, but not clinically proven right now. Clinically, they have sign and symptom, but diagnosis have not made. This is presumptive case. Now you have a case which looks like a TB. You will order 2 tests, sputum, chest X-ray. Sputum, chest X-ray. Now, the results of the test are out. Right? Result of the test are out. Number 1, the patient is positive on sputum and chest X-ray. This is one scenario. Second scenario, patient is positive on sputum but chest X-ray negative. I don't care if I see the bacilli, I am going to label it as microbiologically confirmed TB. Now, scenario number 3, the patient is negative on sputum, but chest X-ray is positive, but I cannot see the AFB. And the last scenario is negative on both. Last scenario is negative on both. Now, if it is the sputum is positive, I don't care about anything. Sputum is positive. I have seen acid fast bacilli AFB. I'm going to label microbiologically confirmed TB. If the sputum is negative, chest X-ray positive, or sputum is negative and chest X-ray both negative, then this is a question for me, because the patient clinically seems to be tuberculosis patient. What I'll do? CB naught. What I will do? CB naught. Right? So what I will order? CB naught. Now if you have a presumptive TB patient who is HIV positive, presumptive TB patient HIV positive, boss kuch nahi karna, directly order CB naught. Directly order CB naught. Fine. Directly order CB naught. Right? Repeating again. Quickly, focus here. Repeating again. Presumptive TB, go for sputum and chest X-ray. 4 options, both positive, sputum positive, then sputum negative, chest X-ray positive, and if sputum positive, microbiologically. If not, CB naught. Right? Now, if people living with HIV, go with CB naught. Right? Now, next is, the scenario is, CB naught will tell you MTB detected, bacilli detected. Second scenario, not detected. If MTB not detected and still you are sure that this is TB, I'll tell you one story. One of my very good friend, his 3-year-old kid developed a lymph node here, right? And the doctor was sure that this is tubercular. No, lymph node, swollen lymph node. The pediatrician was sure this is a tubercular. And biopsy was taken, AFB was done, slide was done, nothing. Right? Nothing. No clinical evidence, no diagnostic evidence. The doctor said this is a clinically diagnosed TB because I am sure that this is TB. What I want to say is in that case, the doctor started ATT without evidence. And what happened after 1 month? the lymph node started regressing. Right? All I want to say is, if you are sure, you can start ATT. If you are not getting any evidence, in that case we say this is a clinically diagnosed TB. Or you have another option, now you make any other alternate diagnosis. Now coming back to MTB detected. Now if MTB detected, right, if MTB detected, then I have either it is rifampicin sensitive or rifampicin resistant. Start the treatment accordingly. But if it is rifampicin intermediate, it is not able to decide that it is a resistant or a sensitive. In that case, you repeat CB0, right? We repeat CB0. Intermediate means not sure whether it's resistant or sensitive. Repeat CB0. And then if again on CB0 it comes intermediate, now we do line probe assay. Right? Now we do line probe assay. Done? Right. We never repeat the sputum. In the recent guideline, sputum never repeated again. Now, okay, guys, listen. Guys, listen. For me, this class is very important because this is about all your high yielding topics in your exam. I cannot rush, right? I cannot leave the topics. What I can do is, because you guys are hungry, what I can do is I can give you a lunch break, right? Let us quickly have lunch break and let us be back at 3:15, right? All right. So guys, we just took a lunch break, a small lunch break, because many of you were not able to focus. Now you don't have any reason. You don't have any reason, right? Lunch done. Now, this is one thing. Now, second thing is, many students, they have hope. They are in this class with some hope. I will not betray them, right? I will not just pass the time because you know, I will give my best, right? This is my responsibility. One thing I expect from you, to have little kindness, little patience, right? PSM, our responsibility. I will do it, right? Just be little respectful with your colleagues. Let us focus and let us crack this exam, right? Let us crack this exam. What I am discussing here is all the keywords, all the high yielding stuff with a trick to remember, right? Can we go ahead? Right? Can we go ahead? Okay. So I was talking about TB and NTEP initiatives. One is Nikshay portion. 500 per month is given to the patient. 500 per month is given to the patient. TB travel reimbursement. If someone is coming from remote area, rupees 750 is given. For notification, 500, and if the successful outcome, it is 500. And if someone is not notifying TB, then IPC 269 and 270. Now, what is TB supporter? TB supporter means a person who will accompany the TB patient and who will help the TB patient in taking treatment. That is TB supporter. In drug sensitive, 1000. In drug resistant, 5000. Right? What is TB Mukt Panchayat? This is a program. This was launched by PM on World Tuberculosis Day. This is just one line you need to learn about this. This is for the community participation. Here we will do community awareness. Now, TB preventive therapy. TB preventive therapy is the therapy which we give to prevent tuberculosis. We have one regime, that is 6H, daily isoniazid for 6 months is given. We have isoniazid, rifampicin, isoniazid, rifampicin. There is one error here, just a minute. There is one error here. It is not daily, it is weekly. It is weekly. 2 drugs, isoniazid, rifampicin, weekly for 3 months. There is another program, newer initiative, Nikshay Mitra, community support to TB patient. Community support to TB patient, right? So what is Nikshay Mitra? Nikshay Mitra is any organization or individual can be a Nikshay Mitra. Here we have to adopt a TB patient and we have to provide the necessary needs. We have to provide the necessary like food and all of these things. This is Nikshay Mitra. Minimum 1 year is required. For just these 2 topics, Nikshay Mitra and TB Mukt Panchayat, just have a rough idea before exam. ART. When to start ART? As soon as possible. Preferred regime of ART, TLD, tenofovir, lamivudine, dolutegravir. Preferred regime of ART for pregnant and lactating, same TLD. Same TLD. Guys, there is one story here. Dolutegravir causes neural tube defects. So that, but still we give in pregnancy. What we do, we timely keep on checking for neural tube defects, timely screening. But dolutegravir is always given. It has a very good response. If I talk about TB and HIV together, then start ATT first. After 2 weeks, start ART. If it is a case of TB meningitis, then you have to start it after 4 weeks. Then start after 4 weeks. What is the regime for post-exposure prophylaxis? Start TLD ASAP and give it for 28 days. Start TLD as soon as possible. Give it for 28 days. If I talk about opportunistic infection, then we have this for PCP. If CD4 is less than 350, we give cotrimoxazole. Right? For cryptococcal, if CD4 is less than 100, start fluconazole. Right? Start fluconazole. For Mycobacterium avium complex, if CD4 is less than 50, start azithromycin. Start azithromycin. MAC CD4 less than 50, start azithromycin. Now coming to blood safety, for HIV, before doing blood transfusion, we check for syphilis, malaria, HIV, hepatitis B, and hepatitis C. And hepatitis C. SMH3. SMH3. Right? SMH3. Now coming to 90-90-90. Okay, what is 90-70-90? Can you write in the chat box 90-70-90 in the chat box? Yes. 90-90-90 is for HIV. 90% of people living with HIV know their status. This is in your workbook. I have given this image in your workbook. Those who know their HIV status, 90% of them should start ART, and those who are on ART, 90% should have low viral load. Right? Now coming to infant born to HIV mother, I have a gut feeling this is important. So what is an infant born to HIV mother? So a newborn, but the mother is HIV positive. The status of newborn might not be clear, right? So in this case, if a baby is born to a mother who is HIV positive, we give ARV prophylaxis. ARV prophylaxis broadly they say give nevirapine, but recently Government of India guidelines are changed. The guidelines say if it is a low risk and high risk, you check for this. If it is a low risk, then Who is a low risk? The mother, where viral load is less than 1000. And the mother is on ART. This is a low risk mother. In this low risk mother, okay, now who is a high risk? Mother not on ART, and even if she is on ART, the viral load is not suppressed. Now in low risk, we give nevirapine. Only nevirapine is needed in low risk, right? Only nevirapine is needed in low risk. But in high risk, nevirapine and zidovudine both are given, right? Both are given. For 6 weeks, this is given nevirapine. Now, if it is a high risk mother, the duration depends. ERF means exclusive replacement feeding. Never, breastfeeding was never given. Breastfeeding never given. 6 weeks. But if the baby is on breastfeeding and mother is high risk, you need to give nevirapine plus zidovudine for 12 weeks. Mark my words, this is very important. Right? Now, this cotrimoxazole is given for pneumocystis pneumonia, right? The infants, the babies, they are at more risk if HIV adult is compared with HIV baby. HIV baby is at higher risk of getting pneumocystis pneumonia. That is why cotrimoxazole is started from the 6 weeks, right? And if I talk about immunization, all vaccines including BCG can be given. All vaccine can be given to a baby who is born to HIV mother. Now, in one slide, we have compiled about diseases under NVBDCP, vector-borne disease control program, malaria, dengue, chikungunya, filaria, JE, Kala Azar. Among all of them, this is by mosquito except Kala Azar, which is by sandfly. Then if I talk about Vivex, Plasmodium vivex treatment, chloroquine is given 25 mg per kg in 3 divided doses. First day 10, 10, 5, right? And along with that, primaquine is given for 14 days. 0.25 mg per kg for 14 days. If I talk about falciparum treatment, then in Northeast we give ACT-AL, right? In here, artemether, lumefantrine, primaquine. For other than Northeast, because in Northeast we see resistance from ACT-SP. Other than Northeast, we have ACT-SP, artesunate, sulfadoxine, pyrimethamine, and primaquine, right? Pyrimethamine. So guys, they ask you the duration. If I talk about the duration, this is given for 3 days. And primaquine is given only on day 2. Primaquine is given only day 2. This artesunate is given for 3 days. This sulfadoxime and pyrimethamine is given only on day 1, and primaquine only on day 2. Primaquine only on day 2. Now there are some malaria indicators. Annual blood examination rate. Annual blood examination rate, the formula is number of slides examined divided by population. The MCQ last year, the MCQ was, which is the index of operational efficacy. ABER is the index of operational efficacy. Then we have annual parasite incidence, slides positive divided by total population. Annual falciparum incidence, falciparum slides positive divided by population. Then slide positivity rate and slide falciparum rate. Slides positive divided by slides examined is slide positivity rate, right? Now, if I talk about the chemoprophylaxis for malaria is short term and long term. Short term, we give doxycycline daily. Long term, we give mefloquine once in a week, right? This is for chemoprophylaxis, doxy and mefloquine. Now, This coming to the national framework for malaria elimination in India. What is category 0? Category 0, when no case of malaria, it is category 0. Here we do prevention of re-establishment phase. Then those state or UT which have API less than 1. API less than 1, right? Suppose if I talk about a state, the whole state API less than 1. And the all districts also API less than 1. This is category 1. Here this is elimination phase. If the state API is less than 1, whole state less than 1, but some of the districts still they have more than 1, but whole state less than 1. This is category 2. Here we do pre-elimination. Next we have is states where more than 1 API. Here we say intensified control phase. Intensified control phase. This statement as it is was asked in your last year. This was asked in your last year inicet exam, right? This was asked in inicet exam. Okay, chickenpox, measles, rubella. These 3 topics came in NEET PG 23. These 3 topics, very important, right? Very important. Very, very important. Now coming to chickenpox. If I talk about chickenpox prevention, right? I'm not going in the microbiological aspect of chickenpox. If I talk about, right, microbiological aspect, I'm not going. And now, vaccine. Chickenpox vaccine is a live attenuated vaccine. Strain is OKA, OKA, 0.5 ml subcutaneous is given. This vaccine is a live attenuated vaccine. So contraindications will be pregnancy, immunocompromised, and this chickenpox specifically is also contraindicated in infancy. Now, if the exposure is there, and vaccine cannot be given, so in that case we give immunoglobulin. The dose is 12.5 international unit per kg to high risk pregnant immunocompromised neonates within 72 hours. Suppose you have pregnant women, they are at high risk. If you have a case of pregnant women who got exposed to chickenpox, right? Here the chances of congenital varicella are there. You need to give immunoglobulins. But if a non-pregnant lady came to you and she's not pregnant, she got exposed, in that case you need not to give this immunoglobulins, because immunoglobulins are only given to high risk. Who are high risk? Pregnant, immunocompromised, neonate within 72 hours. Now these 2 points are given in PSM textbook, but the guidelines, pediatrics textbook, the Nelson and the other guidelines say that if you have a pregnant woman, she came 5 days after exposure, right? 5 days after exposure, vaccine is not given, but 72 hours also lapsed. In that case, you can give acyclovir. In that case, you can give acyclovir. This is very, very, very important, right? From last 2 years, back to back, question was asked on this topic, chickenpox, right? So this is a revision class. DVT is a revision class. I'm not going in the detail of chickenpox, but this is important, right? Now coming to measles. In measles, rubella, I'll be talking about only and only the keywords and previous questions. Incubation period of measles, 10 to 14 days. One episode of, measles. Incubation period of measles, 10 to 14. One infection gives lifelong immunity. In measles, we see Koplik spot. This image was given in your exam in NEET PG 2023. Koplik spot. These are the white spot in the inner mucosa. They appear 1 to 2 days. They appear 1 to 2 days before rash. They appear 1 to 2 days before rash. And rash, first time the measles rash appear before year. If I talk about chickenpox, the first rash appear either on chest or back, right? Now, first rash appear, because these are all asked once in your exam. Next is complication. Most common, otitis media. Most deadly, pneumonia. Most deadly, pneumonia. Right? Deadly pneumonia. Now, treatment. Treatment about measles. Supportive treatment. We don't have any specific antiviral. And we give ORS and vitamin A. Guys, I want to tell you one concept. Measles and vitamin A, they are interlinked. If a child is of vitamin A deficiency, he will get severe measles. Case number 2, a child with measles, but till now he is not having vitamin A deficiency, right? A child with measles is at risk of vitamin A deficiency. That is why vitamin A is given in case of measles, and also vitamin A is given with at 9 months with measles vaccine, right? Rubella, congenital rubella triad, cataract, sensorineural hearing loss, heart defects, PDA. This line was given in NEET PG 2023. Then in rubella, carriers are more than cases. More carriers are there. This line is very important for your MCQ. Infection in early pregnancy increased risk of anomalies. Diagnosis, IgM positive at birth or IgG after 6 months. IgG after 6 months. This slide sorted, very important. Do not forget, very important. Right? Very important. Now coming to diphtheria. In diphtheria also we have more carriers than cases. So you have to manage diphtheria case. You isolate, right? Isolate. And diphtheria is happening because of the toxin. Even if you give antibiotic, the toxin is still there. So you need to give antitoxin. You need to give antitoxin with antibiotics. Which antibiotics? Erythromycin, penicillin. Now you have a contact. Right? Now you have a contact. In this case, quarantine. I told you, for cases we do isolate. For contact, we do quarantine. So you have a suspected contact. You quarantine, take swab and give for the testing, right? If unimmunized, you give vaccination. According to recent guidelines, according to WHO, Indian guidelines, Harrison, Nelson, every source say that you, irrespective of vaccination status, irrespective of immunization status, we give erythromycin or penicillin. What about carriers? What about carriers are important? Carriers are also there. If you have a carrier of diphtheria, erythromycin is given because penicillin is ineffective. Influenza. Just 2 points. Influenza, I want to tell. Rest, your microbiology. Influenza. Vaccine strain change every year. Few years back, this was the question, which vaccine strain changes every year? It is influenza. Second point, live attenuated. We have live attenuated vaccine is nasal route, 2 to 49 year, contraindicated in pregnancy, comorbidity more than 50 year, and immunocompromised. Now, filariasis. Again, you want to see how important this slide is? See, filariasis. This was asked recently in your NEET. If I talk about Japanese encephalitis, the vector is Culex. Amplifying host is pig. Treatment, supportive, and control, vaccine and vector. Guys, filariasis, it is because of the filariasis, the microfilaria. It appears in blood at night. See, filariasis, we have 2 things, microfilaria and adult. Adult are there in lymphatics, microfilaria are there in peripheral blood. So nocturnal periodicity is seen. To prevent this, because at night the microfilaria are going to appear. So to prevent this, we give DEC provocation test. 100 mg DEC given, and after giving 100 mg DEC, within 15 minutes, the microfilariae, they reach in blood. How do we prevent it? We give MDA in endemic areas. Ivermectin, DEC, albendazole. Mnemonic is IDA, ivermectin, DEC, albendazole. And what is the treatment? 6 mg per kg. DEC is given per day for 12 days. And one MCQ in one MCQ was there about this. DEC is only effective for microfilariae, not adult. Now, transmission assessment survey is your inicet question. It is done after 5 to 6 rounds. MF microfilariae in blood. It is done after 5 to 6 rounds of MDA. This transmission assessment survey is satisfactory. We stop MDA. Now coming to Kala Azar, vector is sandfly. Kala Azar, vector is sandfly. NEET PG 21 question was RK plus 39 is used. It is RDT kit, rapid diagnostic kit for Kala Azar. Drug of choice, liposomal amphotericin B, single dose is given, 10 mg per kg. This can be given to a pregnant woman. This can be given to a pregnant woman, right? So this can be given to a pregnant woman. Now, a very important point. Earlier, DDT was used for sandfly, but now Government of India says synthetic pyrethroids. Synthetic pyrethroids. Sorted, right? This slide sorted. Done, guys? Done? Done, guys? How is the Josh? Yes, how is the Josh? Can I get some smileys in the chat box? How is the Josh? We are about to finish. Yes, guys, how is the Josh? Can I get some smileys in the chat box? Superb, beta, superb, superb. Chalo, next. RTI STI kit. RTI STI kit, this is very important. Kit number 1 is a grey kit. NEET PG 2023 question was there. Kit number 1 is a grey kit. This is for urethral and cervical discharge. Mnemonic is grey AC. Repeat with me the mnemonic, grey AC. In next 2 minutes, you will never forget the drugs. Grey AC. We have white AC. We have seen white ACs. Have you seen grey AC? Yes. Azithromycin. Azithromycin AC. Azithromycin AC. So grey AC. Right? Grey AC. Right? Grey AC. Right? Grey AC. Sorted? Now, kit 2 is green kit for vaginal discharge, and we have secnidazole and fluconazole. Secnidazole and fluconazole. White PA. Mnemonic is white PA. Right? And mnemonic is white PA. White PA doesn't necessarily mean a Russian PA. It can be American PA, right? So it is not white PA. Doesn't mean Russian PA. It can be American. It can be, right? White PA. Penicillin azithro. White PA. Penicillin azithro. Next we have blue kit. Bad boys. Bad boys like 2 colors. Blue and black. Azithrodoxy. Bad. B for blue. Bad. Right? Bad boys like blue and black. So blue kit, azithrodoxy. B for blue, A for azithro, D for doxy. Bad boys also like black. B for black, azithrodoxy. Right? Now, red cycle. A red cycle. A red cycle. A red cycle. Acyclovir. A red cycle. Acyclovir. Acyclovir. And next, we have this logo. Which logo? Yes, guys, which logo? For abdominal pain. MECD. Metronidazole. cefixime and doxy, metronidazole, cefixime and doxy, MEC-D, metronidazole, cefixime and doxy. Done, sorted. Now coming to rabies. If the dog licking of dog is category 1. We do only washing. If the dog bites but no blood, category 2. Here we give washing plus vaccine. But if there is a blood, then we give vaccine plus immunoglobulins, and this is category 3. Okay, green mnemonic. Green color stem with green color flower. Green stem with green flower. Done. Now coming to pre-exposure prophylaxis. For rabies pre-exposure prophylaxis, 3 doses are given, 0, 7 and 1 dose, either or 21 or 28, 3 doses. For re-exposure, 2 doses are given, 0 and 3 days. 0 and 3 days. Okay, what if dog scratch? What if dog scratch? It depends, the blood came or not. Now next is re-exposure. If within 3 months, you need not to do anything, just wound washing. If within 3 months, wound washing. But if immunoglobulins were given in last, okay, what is re-exposure? So if you have a case of re-exposure within 3 months, nothing to do. If the wound exposure, if it is a re-exposure after 3 months, if the re-exposure after 3 months, then you need give only then immunoglobulins are not given. Post-exposure prophylaxis, vaccine, you have tourism, intradermal 03728, then 0371428. Immunoglobulins are given in category 3. If immunocompromised, then in category 2 you also give immunoglobulin, human 20, equine 40, right? As much as immunoglobulin dose should be infiltrated to the wounds carefully. No need to give 7 days after bite. Right? And RIG should brought to room temperature. See, guys, if I talk about immunoglobulins, you give to the local wound. If it is not possible, you can give IM also. You give local wound, right? So this is rabies, very important. Rabies is very important. This is modified thigh. Yes. Now coming to immunization. At birth, Bob. The mnemonic is Bob, B-O-B. So I'll be writing those who feel difficulty in memorizing this. Bob, at birth, Bob, BCG, OPV, hepatitis B. At 6 weeks, you give Porip, P-O-R-I-P, Porip. At 6 weeks, Porip. At 10 weeks, you give only Por. At 14 weeks, you also give Porip. At 14 weeks, again Porip. Penta, OPV, Rota, IPV, PCV. And at 9 months, the mnemonic is Michael Jackson is VIP, MJ VIP. At 16 to 24, MJ is no more a VIP. Let us do some work. So MR, JE, DPT, OPV. 5 years, DPT booster, OPV booster. At 10 years and 15 years, TD. At 10 years and 15 years, TD. So 2 times NEET PG21 and 23. This question was asked, and the question was 5th class boy. So this is important. This was asked many times. Now coming to open vaccine vial monitor. So we have an indicator, outer circle. This is for only comparison. Inner square is a chemical indicator. and these two we use, right? So here the outer circle is equal to inner square. We discard. These two are discarded. These two are discarded, right? Now, so VVM location, if it is on cap, it means, so VVM is on cap, you remove the cap and threw the cap. So that means you cannot reuse the vaccine after 4 hours, right? It means it does not follow open vial policy. And if it is on vial, it means it follow open vial policy, right? These 2 points I want to tell you, this is important. Now coming to open vial policy. Open vial policy, so to prevent, before 2011, 2013, every vaccine we used to open and we used to throw it after 4 hours, right? But then open vial policy came. It said once you have opened the vaccine vial, you can use it for 28 days. Temperature should be maintained. Date and time of vaccine opening should be mentioned. Expiry should not pass. VVM is okay. And the septum is not submerged. So this is vaccine vial. This is the top. So what you did? You put the syringe. You took some vaccine. This is the septum. If it is submerged in water, it can be infected. So this is open vial policy. This is applicable. This is applicable for all of the vaccine except not applicable on 3. BCG MR under National Immunization Schedule and COVID. Shake test is for freeze damaged vaccine. Shake test is for freeze damaged vaccine. Shake test is for freeze damaged vaccine. Now coming to BCG, the strain Danish 1331, measles, Edmonston Zegub, mumps, Geril Lenin, rubella, RA27/3, JE, Indian Kolar 821568XY. The new JE is Indian Kolar strain. The old JE was SA1414-2. Many people, they are confusing that new is also SA1414-2. SA1414-2 is a Chinese strain. Now in new strain we have used Indian Kolar strain. Yellow fever 17D. Varicella Oka OKA. Sorted. Now if I talk about the maximum age, the mnemonic is BRIP. The mnemonic is BRIP, BRIPP, BCG, Rota, IPV, Penta, PCV. This can be given up to 1 year. After 1 year, we do not give the first dose of these vaccines. Then 5 year, we give MOV, measles, OPV, vitamin A. Up to 7 year, DPT. Up to 7 year, DPT. Right? Now, this is UVIN. Guys, you must have heard about CoWIN. What was CoWIN? CoWIN was a software. It was an app where we used to register for the vaccine. Similarly, they have already done it. UVIN, right? You must have heard about MCP card, jahan pe we used to mark about the vaccine. This is UVIN. This is a software for the Universal Immunization Program. Then we have EVIN, Electronic Vaccine Intelligence Network. Oral, we gave OPV Rota, then BCG FIPV 3 here given, Penta hepatitis B, JE, PCV here, MR, FIPV 1, 2, and intramuscular Penta hepatitis B, JE and PCV, and JE and PCV. Then we have MR. Now only subcutaneous vaccine is MR. Earlier MR and JE was subcutaneous. BCG and FIPV is intradermal. BCG and FIPV is intradermal. Do not worry about the PDF. PDF will be there. Just learn with me some tricks, right? Just learn with, I told you earlier, right? I promised that I will give you the keywords, the PYTs and the mnemonics. Now, MCH indicators, maternal deaths divided by women in reproductive age is maternal mortality rate. Maternal deaths divided by live birth is maternal mortality ratio. Guys, if I talk about stillbirth rate, stillbirth divided by live birth plus stillbirth is stillbirth rate. Stillbirth plus early neonatal mortality, that is within 7 days of birth, it is perinatal mortality. Neonatal mortality, first neonatal mortality is first 28 days. Then we have infant mortality till 1 year, then under 5 mortality till 5 years. The denominator is live birth. Guys, in NEET period 23, there was a question: which of the following indicator reflects socio-economic development of the country? It is infant mortality rate. It is infant mortality rate. So the current maternal mortality rate in India is 6. Maternal mortality ratio is 97. SDG target less than 70. SDG target for neonatal mortality less than 12. SDG target for under 5 mortality is less than 25. In India, the neonatal mortality is 20, right now 28, and here 32. Here 32. Under 5 mortality rate in India is 32. Right? It is 32. Now coming to MCH. ANC visits, minimum. Ideal are 13 to 14. Minimum according to recent WHO 8. Government of India, minimum 4 visits should be there. If I talk about pregnancy, 2 doses of TD is given 1 month apart. First dose is as early as possible. If the woman is coming in first trimester, you give the first dose. Whenever the lady is coming as early as possible, you give it. Right? As early as possible is the guideline. If previously within 3 years, then only 1 booster is needed. If I talk about IFA tablet, the elemental iron 60 mg, folic acid 500 microgram. It is given before 180 days before delivery and 180 days after delivery. 180 days before delivery, 180 days after delivery. So you can say 6 months in pregnancy, 6 months in lactation. Mid upper arm circumference is measured by Shakir's tape. The image is Shakir's tape. 6 months to 5 years, this is used. Less than 11.5 centimeter is severe acute malnutrition. 11.5 to 12.5 is moderate, and more than 12.5 is normal. If I talk about growth of baby, weight for height gives you acute malnutrition. Height for age gives you chronic malnutrition, and weight for age gives you acute on chronic. Right? Right? It is chronic. Okay, fine. Okay, I understand your point, Dr. Mayuk, I understand. Now, healthful school environment, 10 square feet space for each child. Then 25% should be the window area in class. 40 students in one class. For 60 students, there should be 1 urinal. And for 100 students, there should be 1 latrine. There should be minus type desk. So guys, this is minus type desk. What is minus type desk? So this is minus type desk where the chair goes a bit inside the table level. If it is parallel, it is 0 level, and if it is far, then it is plus type desk. It is plus type desk. Right? It is plus type desk. Now coming to demographic cycle and fertility indicators. Demographic cycle and fertility indicators. Guys, this is demographic cycle is very important. Stage 1, when birth rate is high, death rate is high. Stage 1, when birth rate is high and death rate is high. right? Birth rate, death rate. Then stage 2, the birth rate is high and the death rate now starts declining. Stage 2, birth rate is high, death rate starts declining. Stage 3, the birth rate starts declining, death rate further decline. Death rate further decline. Stage 4, birth rate is low, death rate, they both are low. Stage 5, now the birth rate are very low and death rate also low, right? So if I talk about stage 1, the birth rate is high, the death rate is high. Stage 2 and stage 4. In stage 4, both are low. Stage 1, both high. Stage 4, both low. Stage 2, birth rate is high and death rate starts decreasing. In stage 3, the birth rate starts decreasing, death rate further decrease. In stage 5, birth rate is very low, the death rate is low. The death rate is low. Demographic gap, you see the gap? You see the gap? The gap is narrow in 2 stages, stage 1 and stage 4. See, the gap is narrow. The gap is narrow. Then the gap here starts expanding, and here also the gap is expanding. And stage 5, this is reverse. Now the gap is reverse because birth rate very low, death rate low, right? Now population, when the gap, more people taking birth, more people dying, stable. The population is stable. Stage 4, the population will be stable, but population will increase in these 2 and the population will start decreasing. The population will start decreasing, right? Now recently the question was asked on this one. What is crude birth rate? Total birth per 1000 population. Current value of India 19 per 1000 population. General fertility rate, total live birth plus total live birth per 1000 women in reproductive age. Crude birth rate per 1000 population. Total fertility rate, women in reproductive age. What is total fertility rate? Average number of children a woman would bear in her entire lifetime. Gross reproduction rate. Current TFR for India is 2.0. Gross reproduction rate, average number of girls a woman would bear in her entire lifetime. And net reproduction rate, average number of girls a newborn girl would bear in her entire lifetime, right? Average number of girls a woman would bear in her entire lifetime considering mortality. Guys, 3 very important. Average number of children, TFR. Average number of girls, gross reproduction rate. Average number of girls a newborn would bear, net reproduction rate. Second MCQ, which of the following considers mortality? It is net reproduction rate. It is net reproduction rate, right? So guys, okay, guys, I tell you one thing I tell you, this session, your total questions, these first chapters are very high yielding. You after your exam, you tell me out of total PSM questions, 60 to 70% will be from this session only. Have patience, right? We are just finishing in another 5 minutes, right? Have patience. Your 60 to 70% questions will be from this, and right now coming to health programs. JSY. Okay, so guys, India right now, for your MCQ purpose, India is in stage 3, right? Because the data is about to come, right? The data is about to come. For your MCQ, India is in stage 3. That's it, right? For the data is about to come, right? Now, JSY. JSY is your NEET PG 2022 question. Cash incentive given to promote institutional delivery. We want pregnant women to come to the hospital and deliver there rather than at home. For this purpose, we are giving cash benefit. If she is from rural area, she gets 1400, and if she is from the high performing state, she gets 700, right? Rural, low performing 1400, high performing 700. Asha also gets the money because Asha accompanies that lady 600. In urban, of low performing 1000, 600 for high performing. Here Asha gets 400. Here Asha gets 400, right? Beta Aditya, I think you are listening half information. I said from this session 7 chapters which I am taking, rest which Siddharth sir took. So 60% from this session and rest from Siddharth sir's session. All I want to say is the high yielding chapters these are. Let us not grasp the half information. Pradhan Mantri Matru Vandana Yojana. Here also we give cash benefit of rupees 5,000 in 3 installments. Now one point, the low performing state, Bimaru, Bihar, Madhya Pradesh, Chhattisgarh, Assam, Rajasthan, UP, Uttarakhand, right? Yes, you need to remember the amount. That was the question. Okay, I'll tell you what was the question. A lady delivered in urban area of Madhya Pradesh. In urban area of Madhya Pradesh, tell the amount, right? So Madhya Pradesh, you should also learn which is a low performing and which one is a high performing. In Pradhan Mantri Matru Vandana Yojana, we give 5,000 in 3 installments. But this scheme is under Women and Child Development Ministry. JSY is under MOHF, Health Ministry. This is under Women and Child Ministry. So here 1,000 for early registration. Next 2,000 at least 1 ANC completed, and rest of the 2,000 after childbirth. This is given only on first child. This is only given for first child, right? Now JSSK, in this scheme we give everything free. Free transport, free diagnosis, free delivery, free drugs, free diet, free blood. NSSK is the scheme. Nikhil, PDF will be uploaded. In the app only PDF will be uploaded just after the class. Don't worry about that. NSSK, Navjat Sishu Suraksha Karyakram, training of health workers regarding newborn care, right? Regarding newborn care. Next, Suman. Guys, every program is now, Suman is an umbrella program. But for your MCQ purpose, just remember the main MCQ which they can ask is dignified, respectful delivery, right? Just this highlighted point you need to remember, right? Now Lakshya is labor room quality. Next is PMSMA. In this, free antenatal care to pregnant women on 9th of every month. Green, no risk factor. Red. So in this PMSMA, we give free antenatal care. Green, no risk. Green sticker is for no risk. Red when there is high risk pregnancy. Blue with hypertension. And yellow sticker is given to the ANC card, women with comorbid conditions. Right? Now, HB, and C. Here, home visits are done by Asha. 7 visits in case of home delivery on 0, 3, 7, 14, 21, 28, and 42 days. If it is a case of normal vaginal delivery in a hospital, we give 6 visits because the lady is supposed to be there in hospital for first 2 days. Then 3, 7, 14, 21, 28 and 42 days. LSCS 5 visits. It is 7, 14, 21, 28 and 42 days. Now HBYCC, home-based young child care. Here also home visits by Asha, and 5 visits are done here. First visit at 3rd month. Here I am talking about month. There I was talking about days. 3rd month, 6th month, 9th month, 12th month and 15th month. Now what is RBSK? Rashtriya Bal Swasthya Karyakram. Rashtriya Bal Swasthya Karyakram. In this we do screening in age group 0 to 18 year. Screening for 4 Ds. What are 4 Ds? These are diseases, childhood diseases, deficiencies, birth defects, developmental delays and developmental delays. Then we have RKSK, right? This is RKSK. Here this program is for adolescent age group 10 to 19 year. In this program, mental health, life skills, sexual and reproductive health, injuries and nutrition. Injuries and nutrition, right? Injuries and nutrition. Okay guys, just a minute. Okay, I'm sorry, there was some technical issue. Okay, Anemia Mukt Bharat, this is a 6 by 6 by 6 strategy. 6 beneficiary age group. You can see here the 6 beneficiary age group: 6 month, 5 to 19, 10 to 19, 20 to 49, pregnant, lactating. These are the 6 age group. Then we have 6 interventions and 6 institutional mechanism. Now we have National Deworming Day. Biannual albendazole is given. 1 to 2 year, half tablet, 200 mg. 2 to 19 year, 400 mg. Mission Indradhanush is for universal immunization coverage. 12 vaccine preventable diseases: diphtheria, pertussis, tetanus, polio, hepatitis B, JE, rota, TB, Haemophilus influenza B, PCV and MR. Abhiyan Indradhanush is a program where we change bedsheet in ESI hospital as per Vibgyor. Right? As per Vibgyor, 7 colors, 7 color bedsheet every day. Right? 7 color bedsheet every day. Right? Now, Ujala is for LED bulbs. Ujvala is for LPG cylinder. Ujawla is for child trafficking. This is for child trafficking. Right? This is for child trafficking. Today you might be uncomfortable because of the extent of the class, but while revising, I think you will be thankful. Right? So we are about to end the session. Last, we are right. Okay, this is the recent update. The program name is National Sickle Cell Elimination. National Sickle Cell Elimination. eliminate sickle cell disease as a public health program before 2047, right? The goal is to eliminate before 2047. Here the objective is provision of affordable, accessible and quality care, and also to reduce prevalence, right? To reduce prevalence. Strategies are primary prevention, we do awareness; secondary prevention, we do screening; and holistic management and continuum care, right? So these are the strategies. In simple, this is for MCQ purpose, these technical languages. In simple, we have to end sickle cell by 2047. For this, we will be doing primary prevention, we'll be giving awareness. We'll be doing secondary prevention, we'll be doing the screening for sickle cell. And after screening, we will give sickle cell card. This is for male and this is for female. This card will tell the status of individual, whether the case is normal, a carrier or a disease, right? Carrier or a disease. So what we do is we ask, okay, we give the card, and now we say before marriage, you just ask the card of your would-be spouse, husband or wife. You match the card. When you put the card one above, male female card above, there is an indicator here that will tell you, these are the indicators, they will tell you probability of sickle cell. Probability of sickle cell. Okay. Thank you so much. I know it was late. Lunch break was also necessary because many students, they were sitting in our VSAT centers. That was also necessary. And I understand there was the session took more time, but my purpose was, right? But the purpose was you can revise all the content. That is the beauty of this DVT session. You can revise it and high yielding, giving you all the PYTs. I'm thankful to you. I'm thankful for your patience. I'm thankful for your kindness, which you kept, right? I'm thankful for your kindness, right? Okay. Thank you so much. Take care. Bye-bye. Love you all. We have Dr. Siddharth. I have Dr. Siddharth. We both wish you a very, very good luck for your exam. PSM sorted hai bhai. Take care. Bye bye.